All right. So, take 2 of episode 24. Wow. So we're on the road. We're in Kansas City.
Yep.
We are going to be attending the KC, BioNexus KC Disrupt annual event, which is pretty cool. And I'm going to be keynoting it, and we're going to be attending a whole bunch of different activities. So we're literally recording from the hotel room.
Yeah, we're on
today.
the road.
Yeah.
We're on the road in a hotel room.
And hopefully this actually works. But we recorded on Monday, lost the audio, so we're literally going to re-record the show. And,
Take 2 will be better. We'll be a lot smarter.
Yeah, I would imagine. So anyway, to kind of quickly catch everybody up, we missed a full week. My family suffered a loss. We lost my mother-in-law about 2 weeks ago on Saturday, and it was an intense experience. She was an amazing woman, and cancer is brutal. But we had an incredible experience with the healthcare industry, just in terms of the comfort and the time together that hospice afforded us. We were at an Ascension hospice, and so just want to thank everybody at that facility who, really took care of our family and took care of my mother-in-law through that process. And, it's a club nobody wants to be a part of, but unfortunately,
we're all going to be there eventually.
Yeah, it's just sort of a reality of life. So,
and then I'll just mention the hospice is really helpful. You need to get your directives. I need to work on mine so that you have your wishes met.
Yeah, exactly. So anyway, just wanted to thank everyone for everyone who did reach out. Could kind of tell, where I was last time, and could tell I wasn't in an awesome place. Want to just thank you all for reaching out and offering your support. And with that, we're going to dig into the show. And so let's go.
Yeah. So we had the CPI report come out last week on Thursday. We're showing it here on the screen. But for those that are just listening audio only, the less food energy, the core, is coming down. It's making improvements. Of course, we all know the peak, really high inflation in 22 or early 23, and we're making improvements. But I don't know that we are at the 2%. I'm not sure when we'll get to 2%. So it's kind of like a good news, bad news. It is coming down, but I'm not sure that the Fed is going to start cutting rates and coming back, because we're not at 2% yet.
Yeah,
so
that's right. And it's coming down, less food and energy, but of course, unfortunately, and it's also worth mentioning, the world is in turmoil right now. And our thoughts and prayers are with everyone who is suffering right now and who has lost someone. I know someone who lost a sibling in the initial attacks, and it's just a dreadful situation. Part of that is going to, I think, impact the cost of energy, and not trying to equate human lives to the cost of gas, but in the context of how it does impact our economy. Global conflict, war, terrorism, they do have economic impacts as well.
Yeah, I mean, it's bad on all fronts, right? And hopefully some clearer minds will prevail, and we will get to a better place. But it's really bad right now over in the Middle East.
Yes, certainly, nonstop continued escalation of aggression without any willingness to discuss the larger ramifications. And some of the things that are happening now are just no one can stomach. Obviously,
right.
We this is a healthcare show. A hospital being bombed is just, that's just not even, I literally lived in a hospital for a week. I mean, I can't even imagine what that is like. So,
and it really doesn't matter to me who did what. Like, a lot of people are suffering. A lot of people died on both sides, and I really hope that the conflict can at least calm down. Or
yes, that would be great. So, So with that, I mean, I think we're heading into a window of unpredictability as it pertains to the CPI. Global turmoil does not bode well for stable prices as it pertains to energy and
Yeah.
potentially even food. Supply
Yeah.
chains are going to be impacted by this. This is it's going to be a challenge.
Yeah. Yeah. So I think we're going to continue with inflation higher than the Fed wants. I hope they'll relent and start cutting, but I don't know that I see that in the next several months.
Yeah. So wanted to share a little bit about an experience that I had last week. I was with my Aspen Health Innovators Fellows, and we were in the city of brotherly love. We were in Philadelphia.
Yeah.
And one of the things we got to do was go out into the city, specifically into the neighborhood of Kensington, and work hand in hand with public health workers to address people who were suffering from opioid use disorder. And it was definitely very eye-opening for me. I have not had people in my immediate family who suffer from opioid use disorder. I grew up really in the crack era as it pertains to sort of epidemics from a drug perspective. And so I knew what that looked like in Brooklyn, New York. I knew exactly what that looked like. And also I worked out of San Francisco, and so I'd seen the Tenderloin. It wasn't my first exposure to any of this kind of stuff, but I do have to say the neighborhood of Kensington was another level in terms of what I had actually experienced, and also was my first in-person experience with with the people, with the communities, walking through the communities, talking to people, and myself and my friend Rachel, who's also in the fellowship with me, we were walking around the neighborhood with a couple of great gentlemen handing out Narcan to basically anyone. It was indiscriminate, whether you
want it to have for other people or you want it to have for yourself.
That's
or
right.
You don't even ask, really. Just you want to give.
Yeah. We were just giving it out to people in the neighborhood. Everyone knew what it was.
Right.
Everyone knew how to use it. So, it was a living and breathing reality for them. But one thing I wanted to bring up that was very, very new for me was that there is a relatively new but fast-moving drug combination out there, which is a combination of fentanyl, which everyone I think is pretty familiar with, along with a drug called xylazine, which is actually an animal tranquilizer. And on the street, they call it Tranq, Tranq. And they're mixing these two things, I think, to simulate the effect of heroin in terms of like the flow of the high, because fentanyl is a very fast acting
the flow and like how long it lasts.
Yeah. Fentanyl is very, very fast acting, but it doesn't last very long. So I think xylazine is extending the experience, let's call it, by effectively knocking the person out when they're using it, and then they will come to and then be ready for the next fix. So this is very, very dangerous because this tranquilizer it's not an opioid, and so it's resistant to Narcan. So that's bad, right? Narcan was a lifesaver for the opioid epidemic, but now adding this xylazine is really, really dangerous. And also it's got the very dangerous side effect of necropathy. So people's skin is literally dying, and it's not local to wherever the injection might happen. So that skin dying may happen anywhere in the body. And it was really, really devastating to, see the effects of this combination on people. Really, really sad. So for me, this was a little bit of a PSA. We've shared here the link to the DEA's public safety alert, but just want people to understand that the impact of the drugs is actually escalating. These drugs are getting more powerful. They're getting combined in crazier ways, and the damage that it's doing to people is really it's just getting so intense.
Yeah, and I'll say that we have an opioid epidemic, but it's different when you actually see the people there. And we were talking earlier, it's someone's son or daughter that is experiencing this, and we need to get them help, but it's a long road. It's hard to see where we could correct this at any short time, just because there's so many people suffering from this.
Yeah, even down to like where it's coming from. So one of the things that I learned last week was that a lot of this stuff is coming in on ports. So Philadelphia has a very, very, very active, important economic port where tons of, ingress and egress is happening. And there's a pretty strong belief that a lot of fentanyl is coming from potentially adversaries,
Right.
countries that are adversarial with us. Maybe they've had their own experience in the past with being attacked in this way, and so you can see how bringing this in through the ports might be a way to diminish communities across America. So there's so many different ways, and then also keep in mind, I happen to know somebody who they got addicted to opioids because they had a sports injury, right?
Yeah.
And then they were prescribed.
Yeah, you start with OxyContin,
right?
And then it's highly addictive, and then you go to heroin or fentanyl when it's difficult to get the next fill of the prescription, and then it's like this really bad slippery slope that you're stuck.
Yeah.
But I want to go back to the Chinese. I think you're talking about China shipping fentanyl and maybe xylazine into our ports, because that's probably true. If it is true, it's a national security issue as well as it's a huge healthcare issue. The British did that to China 100 years ago, so I certainly can imagine China feeling like turnaround is fair play and we're going to do that. But whether they are doing it or it's some other organization, as our country has to get control of this and try to have a plan to stop it or slow it down and treat the people, help the people.
Yeah, and the sense that I got was that it requires tremendous coordination from multiple agencies. So, you just kind of rattle them off, right?
Yeah.
The DEA, the Custom Borders Patrol, the Coast Guard, right? There's three right there. And then that's going to be mixed in with your local, for whatever city, whatever those agencies are, the police, probably
FBI,
the fire department, the FBI.
Yeah.
So, yes, we have to get a plan, but it has to be a coordinated plan.
Right.
And it's very, very difficult because, again, these are active economic ports, and time to market of getting these goods in and to their official destination is a factor as well, right? And so, skimming through all these things, and then also you have to sort of make sure that everybody that's working at every point in the chain is legitimate and is not actually, a bad actor. So it's a very difficult problem. I think the point I'm just trying to get across is this is a very serious problem, and it's a very complicated problem. This is not an easy problem,
Well, and the necropathy, people are going to die from wounds and untreated wounds on the streets. They're not getting care that they need, and it's going to be really bad. Yeah. So let's go to a more positive story.
It's a good segue. So this Monday it was covered in CNN Health. The headline was "Healthcare Game Changer: Feds Boost Care for Homeless Americans," and it's talking about how there's new payment models coming out of CMS to enable community workers to actually work out in the field. So when you sent this over to me, I was like, Vic, I literally was doing this last Tuesday. I was with community workers, people who literally lived and were born and raised in those communities, delivering healthcare, Narcan, wound kits in the community, walking around in the community. And, I have to say it was effective. It was effective to get the things distributed, to empower people to save a life at the right moment, and to help people take care of other people. So I was really encouraged to see that we are looking at payment models that will enable more of this kind of activity, as well as, it's also just a way to sort of address the labor shortage, especially as it pertains to, licensed, credentialed clinicians that, we're already struggling with.
Yeah. Yeah. So, they're delivering healthcare. You were delivering healthcare, and it's very effective. What I thought was interesting is that it's a federal rule from CMS, but it is being led by Pennsylvania. Maybe because they have this huge problem. California started it a couple of years ago. They lead a lot of things around these kind of issues, but it just now is going to be nationwide. So it's much more prevalent. If you can get paid and reimbursed for this care, you can do a lot more of it than fully charity only.
Exactly. So this was, to me, this was good news. Obviously, lots of unintended consequences, lots of bad actors, lots of fraud, waste, and abuse. We'll have to watch out for all those things. But for those people who actually have good intent, who want to grow these programs, who want to be out in these communities, I think this is a great development. All right, so moving into cybersecurity stuff, really bad cybersecurity issue with 23andMe. And I think this gets into all things in the digital therapeutic personalized medicine world where data was stolen. And there's a lot of lack of clarity about what 23andMe is willing to confirm in terms of what actually happened with the data breach, how much data was actually breached, what was the method of it being breached. But what we know is right now out on the dark web, 23andMe data is out there, available, being peddled, being sold. And what's really dangerous about this is it includes, data on our ethnicity. And so, right. You can see the dark web is already sort of a bastion for, racism and anti-Semitism and other really, terrible things. And so having this sort of data out there is a nightmare.
Yeah, frankly. It's really bad. I mean, there's a lot of stories of hacks getting through, and especially healthcare records. Healthcare is probably the biggest honeypot that people try to attack. But this seemed like a new level, like all the genetic data, all the ethnicity data being out there is really bad. I don't think there's any way to really prevent my data from being hacked in all the different parts of healthcare that I interact with. Mm-hmm. So I don't know. I don't have a good solution for this, but it's going to be an ongoing issue, I think.
Yeah. And I think we're just trying to bring it up. I mean, I've been talking on basically every board that I'm on about the ever vigilant, investments you have to have from a cybersecurity perspective. Yeah. And it's just, and especially in healthcare, right? I mean, I think we're really going to have to start looking at all angles at healthcare providers and the fact that they have to maintain EMRs. We're going to have to stop looking at those as assets solely and really start to explore the liability that's there.
Yeah.
We talked many episodes as we were reviewing Common Spirit's quarterly reports about that huge, 9-figure expense that came from a hack.
Yeah.
The fact that you have to store this data really at the end of the day is a liability. I mean, it truly is. You're not making enough money for the risk you're managing by having to store it and maintain it.
Yeah, I think that's right. And people, I would like to have control of my own data. I mean, it might be, there's been tech companies that have every 5 years, another tech company tries to create a kind of a personal medical record or some different name like that. It hasn't really stuck yet, but I think eventually I want to get control of my own healthcare data, and then I bring it to Common Spirit. I bring it to the doctor or whatever what service I'm looking for. And then they don't have to hold it all.
Be the custodian.
Right.
Yeah.
Right.
Yeah. Agree. I mean, I think distributing the data and distributing the permission capability of the data is certainly a strategy to, limit the value of the honeypot, as you put it, that's out there. All right, into a couple of big moves in the venture world. So Main Street Health, this is, Bill Frist and Brad Smith strike again.
Yeah.
A couple of episodes ago, we were celebrating them being number one in the Inc. 5000 for CareBridge. And now Main Street Health, which is another company that they have in the value-based care space, was able to get $315 million in financing to expand to 26 states. And they have a lot of payers that have invested in this round.
Yeah, Oak is their main financial partner, but they brought in 5 or 6 payers to contribute the $315. I think we have so the health conference in Vegas was a couple weeks ago now, but we've chosen 3. There were hundreds of announcements at Health just because it's a big event and everyone, kind of queues up their new exciting thing. We've chosen 3 that I think are really meaningful. And Main Street raising $300 million from a bunch of payers, expanding in 26 states. It's a great service and a rural health. I mean, we need a lot of support. So I think I'm happy for them. I think it's good.
Yeah. Second story we want to cover is the announcement that General Catalyst is going to buy a health system. So
this was shocking.
Yeah.
Really. I mean, I am excited to see what they buy. And Dr. Mark Harrison was, of course, at Intermountain. He's a great operator, but I don't know I'll be interested to see what they buy. There aren't a lot of the really profitable, well kind of choreographed markets are already bought up. So they'll buy a nonprofit, but it'll be interesting to see if they're able to drive the change that they expect to drive.
Well, we talked about the big merger that they did with Commure, and I think it was Stellus, maybe the name of the company that's in the revenue cycle management space. So combining workflow and revenue cycle management. Now they're going to, so they are certainly talking about, building out a full platform. And I do think that there's an interest to the strategy of, we always talk about the value of the payvider model, which totally aligns the payer with the provider insofar as here's the payment mechanism, here's exactly the data we want, and everything gets co-designed together, right? But there's certainly a ton of inefficiency that happens between the provider and the technology that the provider has to leverage, right? It's very often a hodgepodge, and I think the height of integration that we've seen over the last 5 years has been this wave of health systems saying we're going all in on Epic, and we're going to make every single facility that we have an Epic facility. We're going to get to level 4, level 5, whatever that Epic stuff is. But that really has, I think, been the height of true tech hospital integration that we've seen out there.
Which is pretty pathetic, really.
It's not very good. That's exactly right. So I think the theory here that General Catalyst is putting forth is that you really can build an entire health system operating system, right? And I think they're going to try to demonstrate that with a single health system, have it operate much, much more efficiently, and then I think use that to sort of prove that other health systems really should be using their full platform. Yeah,
I think that's exactly the strategy. And I'm interested to see it roll out. I think there's I'm half of a mind that it's going to be really challenging to buy probably a nonprofit health system. I don't know of a for-profit that they could buy. Maybe they'll surprise me. But buying a nonprofit and then coming in and saying, we have all of this cool tech and putting it on their bureaucracy, maybe they can do it. It'll be fun to watch them do it. I think there's a lot of ways that the existing bureaucracy is going to resist that, and we'll just see how it evolves. They need to find the right culture, and as we talked about with Common Spirit is intentionally trying to shift their culture. It's pretty hard to do with a big ship like that.
Yeah, well, look, it's a pretty good start if you're going to use a very, very successful health system CEO, as opposed to bringing in some tech CEO or something like that.
That's right.
So that's probably a good start for that kind of strategy.
Yeah,
right?
He's well positioned to bring all these tools out. And I'll be interested to see I think it's 50-50. I'm excited to see what they do.
Yep. And then the third story we're going to bring back from health is my friend who's in the Aspen Health Innovators Fellowship, Jen Bushel. She and her team at Delphi Diagnostics launched a blood-based lung cancer screening test. So this means a lot to me on a lot of levels. I'm very, very pro patient sovereignty. I'm very, very pro increase the capability of diagnostics that are out there. I think there are far too many deaths that are happening because of inadequate diagnosis and also
not catching it quickly enough.
That's right. Yeah. And also there was a long freeze in the blood-based testing space because of Theranos, obviously. So, I just want to give a shout out to the Delphi Diagnostics team. I know Jen, she is a person of incredible integrity, and I'm really excited about what they, and really I'm hoping an entire market, start to bring on, which is low cost, high fidelity. And when I say high fidelity, we're not talking 99%, right? We're talking maybe 80%.
It's
accuracy.
A screening test.
It's a screening test. That's exactly right.
So you should be producing. Some of the people that go through the screening test should get a further test.
That's right.
And but I think it's exciting that we have moved beyond the bad actors, and now someone's doing it the right way and bringing a new screening test to market. The reason that the blood-based screening is really valuable, the reason Theranos tried to do it is it's very common. It's easy to draw blood. Every health system in the world can quickly draw blood. You can do it on the corner in a lot of places. And so if we can get more and more screenings through blood-based screening, it would be great.
And I think it needs to be said that a lot of this technology is really based on advances in machine learning and artificial intelligence. And so this is a place where, those advances are really exciting, right? We talk about where is machine learning really going to help in healthcare. I mean, diagnostics is a no-brainer, right? Like more of this, please. So anyway, congrats to the Delphi Diagnostics team. And we're just going to stop. Actually, I want to bring up one other thing, and I don't have the link here, but just going back to the General Catalyst thing, and then we'll go for a break. Going back to the General Catalyst thing, you found this week that a local venture capital firm in Nashville, Claritas, is putting together an offer to take ShareCare, a company that's publicly traded and that they own about 10% of, to take it private. And we were talking over breakfast about, just kind of connecting the dots that, LifePoint Health was taken private by Apollo, and, Ardent is owned by EGI. And, now, those were private equity firms. Now we have General Catalyst and Claritas. We have VC firms, right, looking to take these assets public. And I think there's an overall trend there. We're going to have take them private. Sorry. I think there's an overall trend there about, in this new Fed, increased interest rate market, and also all the capital that's still under management at the growth and private equity stage. There may be a lot of taking things private. And not just from private equity firms, but from VCs.
Yeah, that's what I mean. We know the Claritas guys, they're in Nashville, good guys. And it's pretty exciting to see VCs, General Catalyst, Claritas moving into this space. I think there's a lot of capital out there, a lot of wealthy individuals, institutional investors that are trying to find a place to invest. And the public markets have been, except for like the 5 or 6 tech companies, have been really crushed. And so there's an opportunity to bring ShareCare at a pretty reasonable price, take it private, do some work, try to fix it up. I think healthcare, obviously we're biased, but healthcare is a place where you can make a real difference. Whether General Catalyst succeeds or not, they know what they want to put in place. They will, if they can get it pushed through, they will deliver much better efficiencies, better care, lower spend, more profitable. And Claritas will do the same. They're really good. They can redo ShareCare, kind of get it more efficient, more organized. And then you can monetize it by bringing it back to the public markets when maybe the Fed relents and it's a friendlier time. So it's pretty exciting.
Yeah, and we've also been talking recently about how we're basically at the end of this model of the healthcare industry. And I don't think the public markets are a great place for most companies, a UHG excluded, right? But I don't think it's a great place for most companies to evolve to whatever the next version of the healthcare industry is going to be. I think they really do need to be private, where they're not beholden to, quarterly analyst calls and things like that, where they can really reinvent themselves, leverage technology, rethink the overall business models, take advantage of massive changes that are happening at the CMS level. It's going to be difficult, I think, for especially a lot of provider organizations to do that when they're publicly traded.
Yeah, you can't do a big strategic initiative, reorganizing the entire business in a 90-day cycle when you have to have it all done in the next quarter.
Right.
So you need a little more time, and going private is the way to do that.
Yeah. All right, so we're going to take a break here and let Doug share a little bit about Jumpstart Foundry, and then we'll be back to talk about Kaiser.
Thanks, guys, for the opportunity to talk about our pre-seed fund, Jumpstart Foundry. My name is Doug Edwards, CEO of Jumpstart Health Investors, the parent company of Jumpstart Foundry. We're so excited to be able to talk about early stage venture investing, certainly the need for us to change the crazy world of healthcare in the United States. We are spending 20% of our GDP, north of $4 trillion a year on healthcare with suboptimal outcomes. Jumpstart Foundry exists to help us find and identify and invest in innovative companies that are going to make a difference in healthcare in our country. Every year, Jumpstart Foundry invests a fund, raises a fund, and deploys that across 30, 40, 50 assets every year, allowing ease of access for our limited partners to invest to help us make something better in healthcare. Some of the benefits of Jumpstart Foundry is there's no management fees. We deploy all the capital that's raised every year in the fund. We find the best and brightest, typically around single-digit percentage of companies that apply for funding from Jumpstart, and we invest in the most incredible, robust, innovative solutions and founders in the United States. Over the last 9 years, Jumpstart Foundry has invested in nearly 200 early-stage, pre-seed stage companies in the country. Through those most innovative solutions that Jumpstart Foundry invests in, we also provide great returns and a great experience for our limited partners. We partner with AngelList to administer the fund, making that ease of access not only with low minimums, but the ease of investing in venture much better. We all know that healthcare is broken. Everyone deserves better. Come alongside us with Jumpstart Foundry, invest in making the future of healthcare better, and make something better in healthcare. Thank you, guys. Now back to the show.
All right, we're back. So I think anyone who actually looked at this situation, especially comparing it to other union, strikes that were happening, could see that the Kaiser union was going to be very successful here.
We talked about it last week.
Yeah,
the union did a really good job, and they won.
Yeah.
I mean, there was a negotiation, but they basically won. They got a 21% raise over 4 years. And I'm happy for them. I mean, as you had your experience, we've all experienced healthcare. The nurses and support people are critical. I mean, we need them, and we need them to be paid a fair amount.
And Kaiser had it. I mean, they were doing well enough to do it. So, right. I think it probably, look, I can empathize with health systems, especially coming out of the pandemic, feeling like they need to have a surplus. They need to be, they need to really focus on the cash on hand. I can empathize with that. It's been a brutal, 3 or 4 years for health systems, but at the same time, it's been a brutal, 3 or 4 years for healthcare workers and for individuals, just with the rate of inflation and the cost of goods and services and energy and food. And so, look, I mean, we're all going to have to get through this together. And in the case where the employer is in a strong financial position, which is not true in so many of these union, actions, but in the case when the employer is in a strong financial position, I do think the union actions right now are making sense. And also, I'm glad this one didn't drag out, right? For the benefit of all the people who, go trust and rely on Kaiser as a health system for their healthcare needs. I'm glad they didn't have to have the anxiety of wondering whether or not they were going to get the care they need, for more than a week.
Yeah, that's right. I mean, I think this was the workers went on strike, and then they quickly came to the negotiating table and worked out a deal.
Yeah.
What I think is really interesting is that we were talking last week about, okay, Kaiser's probably going to have to pay up something, and then how will that impact them compared relative to other health systems in their markets? And what's really interesting is that the U.S. Department of Labor was involved in this negotiation, and then Gavin Newsom, the governor of California, came out on the same day providing a new set of rules. I think it's a set of rules or minimum wage at $25 an hour, which matches the Kaiser. So,
right.
So, I mean, I think they had the money. They were probably worried about the competitive dynamics, and California wants to make sure everyone is paid, as I've done with fast food and other things. So, it's really interesting to see. What I think I see is that the labor department was involved in the negotiations and worked out a kind of a settlement.
Yep. No, I'm glad you brought up the fast food, minimum wage action that California put in place. California is going to continue to be an actor, I think, for workers' benefits, but it's going to be interesting because the America is becoming very bipolar, in terms of blue trifectas versus red trifectas, and what a state like California is going to put in place versus, let's say, a state like Texas or Tennessee. And so Kaiser having a huge concentration in California, that sort of makes sense. But as we know, from being in Nashville and knowing basically the general locations where Nashville-based health systems have their have their
unionized
states generally, right? And so I think this is going to create even more of a distinction between the nonprofit and the for-profit space. As the for-profits tend to be very, very selective about the markets they enter, and the dynamics as it pertains to unions and Medicare and Medicaid policies and things of that nature. So we could see even more of a tale of two different states, if you will, as the the political divide continues to push in opposite directions.
Yeah, I think we probably will. I also think that the separation where a health system is kind of working on its own, and then there's a payer, that adjudicates the claims. That's over. And so I think it is going to be a tale of two different kind of environments around the country for a short amount of time. Then hopefully we'll have integrated groups that take on risk. I'd like them to take on longer risk than 1 year at a time. And then if they take care of the people, they benefit from that. And of course, they need to pay their workers. I think it's interesting, going back to our earlier story, California led the homeless reimbursement for homeless care outside the hospital. Mm-hmm. They're leading here with the nurses and support staff wages. So there are some things that, I don't care what state you're in. My opinion is we should do street healthcare and pay people because it's better medicine. It's less expensive. We don't want them to go to the ER and be, really in trouble. It's much better to bring them care.
Yeah, we're meeting people where they are, right?
Yeah.
So I think it's just going to be a situation where we're going to have to watch activity in different states and understand that it's playing out at the financial level, at the for-profit versus nonprofit. And just one caveat to your point about the days of payers and providers not being, aligned and integrated. The only caveat I'll just put to that is, except for those providers that have tremendous scale and are in great markets and operate, their asses off. So like HCA, HCA is not going anywhere, and I don't envision I don't see HCA getting a embedded payer anytime soon. I think they're just strong enough that they can maintain really good relationships with the UHGs and the Blues of the world, and I think they're just going to be fine.
They've chosen their markets in such a way to have strong negotiating leverage with the payers over 30 years.
Right. That's right.
And so that they are really strong. And if someone set out to do that today, it would be hard.
That's
what I think General Catalyst has. I'm not sure where they're headed, but yes, HCA has assembled a really smart set of markets where it's population growth, and they have enough of a presence that they have significant negotiating power.
Yeah. Well, it's really like, the market dynamics and your operational competency determine whether or not your fundamental lever in making money is driving volume or being more efficient and saving money.
Yeah.
Overall, right? It's sort of two different paths. There are very few that are going to be able to do the HCA path as we go into the future.
Yeah.
Very, very few. HCA will be able to continue to do it, but very few will be able to do that path.
Yeah, I think that's right.
All right, final story. We're circling back to the GLP-1 drugs, and so Novo Nordisk has got a huge hit on their hands with Ozempic. Yeah, Ozempic is theirs. Yeah. So they've got a huge hit on their hands with this thing. They just smashed a clinical trial from a kidney failure perspective. So that they're adding more and more use cases to it, which I think is going to increasingly justify the value of what they want to sell the drug for, as it continues to take more and more chronic issues down in its ability to lower overall weight. And it's not only increasing their value and their market cap, but it's also impacting other markets, such as the dialysis market.
Right. Yeah. So just to circle back to the trial, that they ran a trial to see if their GLP-1 weight loss technology could help with chronic kidney disease, and it can. And it was so powerful that they were able to stop the trial. They didn't need to go any further. Why should we give people placebo when we know it's clearly working and we have this huge statistical thing? And so they stopped the trial. And it's really incredible. Maybe I should have known, but loss of weight is really powerful. And so it's about $15,000 for a year of this probably And if you are in sort of chronic kidney disease but not in dialysis yet, that probably makes economic sense to go ahead and pay the $15,000, and now I'm not going to have a bad standard of life. I'm not going to be in dialysis, and I think you save dollars. So the payers will save because they won't have to pay for dialysis. And as you said, pretty immediately when the report came out, DaVita stock was down, and Fresenius was down, and then all the other sort of peripheral companies that sort of do various robotic surgery or other things in kidney disease were down. And that's a wonderful, I feel bad for their shareholders, but it's wonderful for the rest of us. Because what it means is we can have a lower, kind of less invasive treatment, and people can get on with their life by losing weight, which is incredible.
Yeah. A couple of years ago, you came to me and you said, one of your big, theses for innovation in healthcare was that innovation in the pharmacological area was going to eliminate service lines. Right.
Yeah.
As we got stronger with, cell therapies, gene editing, and just generally as we advance more things in the biotech realm, we were going to just eliminate whole service lines. And this is, I think, an indication of that coming to reality. Yeah,
I think that's right. There are contributors to chronic disease. Weight is probably the biggest. I think behavioral health is maybe a little bit of a nebulous term, but behavioral health is the other one that I think is huge.
Massive opportunity.
And if we can sort of get at that foundational health with some kind of drug, the only thing that is keeping me from like jumping up and down on the GLP-1s is they're injected, so it's a little bit hard to scale it, I think. But there's lots of things coming out, and I think yes, we're going to have this coming together of the health systems, the payers, and the pharma companies, all sort of working in the same. It's a health market,
right? All right, we managed to knock this show out in time to move to the next event we have here in Kansas City. So
yeah, and now that we're mobile, we can be reporting from the field all over the place.
Yeah, I'm so excited about that. I literally don't want to travel again this year. I'm so tired of being on planes.
I just want to mention this is our 24th episode.
Yes.
We have, obviously, the 25th next week.
Yep.
And so I think I'd like to talk with you about some of the trends we're seeing over the first 25 shows. What have we seen? And try to give a summary, maybe a little bit higher level view to the audience after 25 shows.
Yeah, for sure. I mean, we definitely have seen different storylines weave in and out, and I think we've come to our own conclusions about things. And I think it's a good milestone. 25 shows to stop and sort of say, what do we think we've picked up, in talking about the healthcare and health innovation landscape over 24 shows. So I think that's a good idea.
Okay, great.
Well, we will see you all next week. We hope you are safe and healthy. And again, our thoughts and prayers are with all of those suffering in the Middle East and all of those who are related to people who are in that region right now. War is just it's a terrible thing, and I think it puts everything in perspective, about how lucky we are when we are in times of peace. And so, may those times of peace return, and until next week.